Afternoon, everyone. This is Adam Myers, the co-director of the Health in the Public Interest Program with Dr. Adrian Fu-Berman, who is also with us this afternoon. And we are happy to be welcoming in a couple of minutes an alumna of Georgetown University, um, Dr. Courtney Pladsen. She'll be introduced by our student, Molly Yesselson, in a moment. But before that, I'd like to just tell you a little bit about the program and how we'll run this seminar. The Health in the Public Interest Program is a program that looks at public health through a lens of, um, of social science. We look at social determinants of health, economic determinants of health, the intersection between various aspects of non-clinical matters in health. So today's talk is definitely in that wheelhouse, and we're really happy to have Dr. Pladsen with us. We'll start by introducing her in a second, and then she'll give a talk of around 40 minutes, followed by Q&A. Molly is going to moderate all of this and call on people to ask questions during the discussion time. We have a hard stop at 1:15. If we need to stop earlier, Courtney, just let us know. But we'll take questions first from the students and then the audience. And Dr. Pladsen has insisted that everyone call her Courtney. So if that kind of is jarring after our usual, a little bit more formal manner, please be understanding. And with that, I will turn it over to Molly.
Thank you, Dr. Myers. So we are so excited to welcome Dr. Courtney Pladsen. She is Maine's Medicaid medical director and has worked in the healthcare safety net for over 15 years. She is a family medicine nurse practitioner and primarily focuses on primary care, substance use treatment, and harm reduction for people experiencing homelessness. She, as Dr. Myers mentioned, she is a Georgetown alum, where she got her master's and her doctoral degrees, and she did her undergrad at Boston College. During her time here at Georgetown, her research explored screening and addressing social determinants of health in primary care, which is something we love to talk about in this program. Courtney was also a fellow with the RWJF Culture of Health Leader program from 2018 to 2022, and the clinical director at the National Healthcare for the Homeless Council from 2020 to 2023. She continues to practice 1 day a week at Greater Portland Health's Healthcare for the Homeless Clinic, and she is passionate about improving health systems to provide equitable care for the most marginalized. And a project she has been working on for the past couple of years focuses on improving health outcomes for people who are transitioning out of incarceration. And I guess it's sort of a fun fact is that because of that program, she has actually been to every jail and prison in the state of Maine. There are 21 of them. And it helped her learn a lot about the state and kind of understand more of the nuances of healthcare in a rural setting. And then her actual fun fact is that she takes her kids and stays in a cabin up in Lovelock, Maine, which is a tiny fishing village and the farthest eastern point in the United States. And it is where dawn hits first in the US, and it is one of her favorite places in the world. So we are so excited to have you. Thank you so much.
Thanks so much for the introduction, Molly, and thanks, Dr. Myers, for inviting me. It's really a pleasure to be with you all today. And I love seeing some old familiar faces, some friends from a long time ago, and some new ones too. So I'm excited about this discussion and this presentation today. And so I'm going to bring up my slides, but before I do that, my hope is to present for a little bit, and this is going to be wide-ranging, talking about homelessness and substance use and harm reduction and lots of different policy pieces. Some of this might be new. Some of you might be experts in parts of this, but these intersections are quite unique when you stack them up. And so I really welcome you all to think of how this work intersects with your lived experience, your passion. I think when we think of working towards and creating equitable health systems or equitable societies, more just societies, housing and economic justice and gender justice and racial justice, all of these things are deeply intertwined. And so this work might be very different than the work that you do now, but I challenge you and encourage you to think of how this intersects with the work that you are doing and the passion that you bring to it. Let me start by just sharing my slides. Oop, it didn't go from the beginning. 1 second. There we go. All right. So we're going to talk a little bit, I'm going to give some overviews of kind of the current state of substance use, overdose, homelessness, and policy, and kind of where things stand now in 2025 as we are. And this is really rapidly evolving. So I'm hoping to just share some policies that have been passed this year and kind of how this is directly impacting my patients, my community, and yours as well. And then we're going to spend some time at the end just talking about how we engage and how recommendations around engaging people with lived experience and how that is essential for us in creating more equitable systems. I wanted to just start by sharing a little bit about my journey. And I, as the state's Medicaid medical director, work now in the executive branch of our state government. But I have been in multitudes of roles within systems, outside of systems. I have worked as an advocate. I've worked as an activist. I've been a primary care provider for many years. But I just wanted to say that there's no wrong way to make a difference, and that you can do that through volunteerism. You can do that through your roles. You can do that in many, many ways, and that your path doesn't have to be one of them. So in the picture on the left is a picture of me and Sam. And if you listen to the podcast that I recommended, Sam was one of my patients. And this is the day she got married. And I brought flowers to that day and got to witness her and her partner get married. And Sam had been experiencing homelessness for many years. And I got to witness her move into housing. And this was a really special day to be there for her wedding. So I was there as her provider, but really as we had really a relationship focused on mutuality. The middle top picture is me doing street medicine in DC, where I used to serve patients on the streets in the capital, where some of you might live. And so on the right is Penny. She's a community health worker who was one of my partners for 6 years doing this work out on the streets. And in the middle is one of my favorite patients, George, who gave me permission to share this photo. But I would see him every single Monday night at Union Station, come hell or high water, no matter the weather. I knew I could see George on a Monday night, and he knew I would be there. And so it's such a gift. People think street medicine is very fluid, or you see this person one time. Nope, I would see people for years and years, and really try to work to build trust in our relationship. The top right picture is during a sleep-in at City Hall when patients, they're my patients, but people experiencing homelessness were protesting in Portland, Maine, where I live. And I was volunteering as a medical provider during their protest. Gave us on the bottom right is every year we have a memorial to mourn the loss of people who died while experiencing homelessness. And this was a picture where I was one of the speakers. And then the bottom middle is me in a primary care setting. So just want to say there are lots of ways to show up to this work. And again, it can be professional, it can be personal. We can work to create more equitable systems from lots of different ways, and I encourage you to think and explore what that can look like in your life, and that can change over time. There's not one way. All right, so we're going to talk a little bit about substance use and kind of where things stand now in 2025. I just want to say at the start, some of these topics are hard and can be heavy, and I'm going to be sharing mostly statistics, but these do equate to people's lives and people who've been impacted by the overdose crisis in our country. And substance use might intersect with your personal experience with people or friends or family members that you know and love. And so if you need to step away from this portion, I understand, but I also welcome you to approach it with curiosity. So where things stand, so every year, SAMHSA does a national study on does a national survey on drug use and substance use. And I just think it's interesting for helping us right size how big of a problem this is and understand really the human impact of substance use disorders. So this is really not anyone who's had a sip of alcohol. It's not someone who just used drugs once. This is, clinical diagnosis of people with a substance use disorder, where the substance use has become so much of a problem that it interferes with their life, their relationships, their ability to work, their physical well-being. And so when we look at the numbers on the right, alcohol is still really one of the predominant substance use disorders. The top number, drug use disorder, this encapsulates all drugs: marijuana, opioids, meth, cocaine, and people can have both. So they're not mutually exclusive. We certainly have many patients struggle with both alcohol and drug use at the same time. But on an annual basis, last year in 2024, you can see about 27.9 million people are struggling with alcohol use disorder, 28 million with a drug use disorder. And by and large, marijuana use disorder was the biggest. And so the folks that I am serving and treating in healthcare for the homeless clinic are by and large struggling with opioid use disorders, meth use disorders, stimulant use disorders in general, and benzos. So a much smaller subset of the population are the folks that I serve. But we really see alcohol use disorder across all levels of economic spectrum. And really, people use drugs across all economic spectrums of our country. It's just that people without homes are doing these or have these behaviors in public settings and they don't have the protective effect of a home to be able to sleep it off or be able to have a good night's rest. And so it really amplifies the negative effect of the substance use disorder. So I just want to state that I know many people, we're going to talk about the bidirectional nature of substance use and homelessness, but we know that people across all economic spectrums use drugs and drink alcohol. So this is the National Vital Statistics Report that tracks overdose deaths over time. And as you know, we're coming down off a 5-year episode of just so much loss of life from overdose death. And so this black line and this brown line both represent opioids. This is opioids in general. This is synthetic opioids, and synthetic opioids are just what are not naturally occurring. So we see a lot of synthetic fentanyl and other synthetic opioids that have entered the market. And so I just want to think for a minute about the human toll of this. We had at its peak 100,000 people a year die from overdose deaths. And I'll just say, when I in my clinic, we started our Suboxone program, which is a medication to treat opioid use disorder, in January of 2018. And during the surge of overdose deaths, we were reversing overdoses and providing Narcan in our bathrooms outside our clinic. We would have a rapid response team have to go out and start, Narcaning people and CPR. The toll that this took in communities is just so tremendous. The personal toll, the collective toll of grief and loss. People that I've been caring for many years now, so many of their peers have passed away. If you used opiates during this time and there were barriers, whether you didn't expand Medicaid or still not a harm reduction approach towards treating people with opioid use disorder, many people struggled to access actually getting into treatment, and in that gap died of overdose. And so we are seeing huge reductions in the rate of overdose, and we've made a lot of wonderful progress. But I'm really concerned that policies that have been promoted and are being enacted this year we could see reversals of this. So I just want to say that we're making amazing progress, and a lot of it has been implementing and focusing on harm reduction, expanding access to treatment, and really spreading evidence-based practices. So these gains are not inevitable, and they're going to take constant work continue to see this come down. But I'll just note that you see these lines here, the gray and pink. This is basically meth and cocaine. This is really steadied, and we have not been making a lot of progress. Most of my patients now who are on Suboxone and are recovering from opioid use disorder are still now struggling with stimulants. And so this is really an ongoing emergent issue that really negatively impacts people's mental health, especially. So making progress, and we want to acknowledge all the hard and good work that has brought us to this point, and we still have a long way to go. Just want to say that state level policies really matter. This chart is showing the percent change in predicted 12-month ending count of drug overdose deaths by jurisdictions from April 24 to 25. So you see the darker blue is showing what percentage reduction in overdose deaths. So you can see here these states in the Mid-Atlantic, New York, New Hampshire, all made really wonderful, huge decreases And there's other states that are still either neutral or are going up. And this is where we see state level impacts making a difference. Who expanded Medicaid? Who are embracing more harm reduction approaches? Who are opening access to substance use treatment? And so much funding for treatment comes through SAMHSA, comes through HHS and the federal government, but then states have a lot of control over how those are implemented, certain policies and programs. And so I encourage you to think of your state where you're and understand kind of how this is playing out in your particular state. In Maine, we've been making amazing. We were one of the worst hit states in the country. We've had some of the worst rates of opioid use disorder in the country, but we've seen year over year, the past 2 years, 20% reductions in overdose deaths, and a huge concerted all-state government effort to work towards that, from prevention to treatment to harm reduction. And so everyone really, it feels like in Maine, in our state government, that everyone's very aligned in terms of that mission and values around this work. But I know that varies state to state. All right, so we're going to talk a little bit about homelessness and how they relate to one another. So this is really hard. So what this is, every year on January 25th, all across the country, we try to do what's called a point in time count. So for people who are in shelter, sleeping outdoors, there are people that canvass all over the country to try to enumerate how many people are experiencing homelessness. This is, I will say, imperfect. In colder places like Maine in the winter, people try to double up. People go and sleep on couches. And so it's not always perfect, but it's our country's best guess at how many people are experiencing homelessness on one given night in the country. And you will see there's a gap, obviously, around the pandemic, but our numbers are soaring. There was a lot of investment during the Biden administration, promotion of housing best practices like low barrier housing with Housing First, improve new funding for the development of affordable and low income housing. And despite that investment under the previous administration, what we saw following COVID, so during COVID, we had suspension of evictions. You couldn't be evicted for a period of time during the public health emergency. When that public health emergency lifted, so was that restriction of evictions. We saw many evictions start to happen, and then simultaneously we saw skyrocketing housing prices. And so that has led us to this really challenging moment that we're in now, where we're seeing the highest number of people experiencing homelessness in our country. And that is inclusive, not just single adults, those are families, those are kids. Shelters are full all across this country, and we're not meeting the need. And as we go through the policies that have been coming through this year, I'm deeply concerned that these numbers will only get exponentially worse. And I want to point out that this, again, that rise, it's not inevitable. It does take concerted policy. So homelessness is solvable with housing. We know that. We know the interventions that work. We have 30 years of research that tells us what interventions work best for certain populations within the homeless community. We need affordable housing. We need low barrier housing. And there's been a huge concerted all federal government effort to address veteran homelessness. And you can see our veteran homelessness has gone to the lowest point in our country's history. So huge juxtaposition of homeless community in general and veterans. One is the highest ever and one is the lowest effort. And this is showing concerted effort and coordination across the VA, HHS, HUD, and others, Department of Education, they're putting funding, they're putting the models out there to address this particular type of homelessness. Homelessness is solvable, and this is actually demonstrating we know that to be true. And it is true in the numbers. And so if our country wanted to solve homelessness, we absolutely could. It takes concerted effort, policy, and funding to make it happen. So this is it. Solving homelessness lacks political will. It's not that we don't actually have the policy solution or the understanding of how to do it. So thinking about the long-term implications on homelessness and health, it's pretty dramatic. Homelessness is a indicator, it's what's the word I'm thinking of? it's an independent contributor to negative and poor health. And so if we just look at the impact of, if we take two populations, or the population, same peer group, but one part of it was experiencing homelessness and the other peer group was placed into housing, we start to see this massive divide in health outcomes. So for diabetes, we see people who are homeless have twice the rate of diabetes as people in housing. Same with hypertension and heart attack. So about you're twice as likely to have those conditions. And that is a reflection of the conditions of homelessness, lack of being able to choose your own food, lack of control over your diet, the stress. We know stress immensely contributes to these disease processes, lack of ability to track your medications, to access health care. If your priority is how am I going to safely sleep tonight, where am I going to get my next meal, you miss your primary care appointments. It's really hard to prioritize your health until you are having extreme burden of symptoms. And then when we get to infectious illnesses like HIV and hepatitis, it's massively inequitable. So really high rates of HIV in homeless populations and hepatitis C, and then the disproportionate experience of mental illness and substance use disorders. And so there was a wonderful study, state of California did a study of, so California has the highest proportion of people experiencing homelessness in our country. And they did a statewide study interviewing people all across their state. And they reinforced this, that 58% of people who are experiencing homelessness have a substance use disorder, and a lifetime experience is much higher. So high burden of substance use disorder. And we see that that's bidirectional, though. We know that being homeless can exacerbate substance use disorders, again, due to the mental illness and stress of being homeless. And so sometimes people use substances as survival tools. We know that people use methamphetamines to stay up at night so they don't get assaulted or they don't get their belongings stolen. We know people who high rates of post-traumatic stress disorder, when you have to live in congregate setting or sleep outdoors and you're fearful, taking benzos or self-medicating with opioids can calm your nervous system. So, and same thing with alcohol. So folks are often using substances just to try to survive. And so we try to, in my work in healthcare for the homeless clinics, just meet people where they are in their substance use and really see as the primary treatment for substance use disorder in this population is first getting them housed and safely housed. And then we could really try to help stabilize them, keep them alive, get them access to treatment, certainly, but it's really hard to maintain any kind of recovery while someone is still experiencing the trauma, the daily stress of experiencing homelessness. So what's interesting when you dig into the data is that where you sleep actually matters significantly. It's not just experiencing homelessness in general. What this is showing is the difference of burden of physical health conditions, mental health conditions, and substance use conditions between unsheltered and sheltered individuals. So again, everyone's experiencing homelessness, but this light blue is really for people who are staying in a homeless shelter. And this darker blue is for people who are sleeping outdoors or who are unsheltered. So the physical health conditions of someone sleeping outdoors, 84% compared to 19%. Mental health conditions, much worse, 78 compared to 50. And substance use disorder, much higher of those sleeping outdoors than in shelters. And then the stark differences between the trimorbidities. So someone who's struggling with all three, 50% of people are sleeping outdoors compared to 2%. And so if we unpack this a little bit, there's a lot of reasons. It might be that someone is really struggling with, they have schizophrenia, they might be struggling with paranoia, and being in a shelter in a congregate setting with a lot of people is too overwhelming. So they're more likely to sleep outside. People who sleep outside are exposed to the elements. They're in a bad storm. They're the first ones to experience the wet from the rain before the wind even shows up. They are more likely to have their tents ruined in a bad storm, snow or rain. If it's extreme heat, all of those extreme elements outdoors are going to be impacted, are going to be felt more severely by someone sleeping outside. We also know the rate of trauma, of violence, of sexual assault, physical assault is very high for folks who are sleeping outside. And so, again, disproportionately experienced by people sleeping outdoors. Priya, I'm just looking at your question. Do you know if there are a number of if the number for substance use disorder is influenced by whether or not shelters require sobriety. I think that's another really good point. So there are different types of shelters all across our country. If you receive HUD funding, federal funding for shelter, you have to have low barrier shelter and accept people regardless of substance use. But there are many shelters that are church run or community run that require sobriety, they require you to not be drinking or using drugs. And so that prevents or precludes someone from being able to access shelter in the first place. And so that is, deeply concerning and can continue to exacerbate folks' mental health, illness, and their use of substances to continue to self-medicate. So just wanted to highlight, and everything I'm sharing on my slides, in my notes, there are links to everything. So if you want to explore that further, I'm going to be sharing the slides with Molly to share with you all, including these research articles that I just wanted to lift up. So the research is really profound. We know, again, that homelessness is an indicator for poor health outcomes, especially from overdose from substance use. In particular, in my role in state government, I'm part of the team that reviews some of the overdose deaths in our state. And often those deaths are due to people using alone. And so folks that are experiencing homelessness who use drugs are some of the most marginalized people in our society. Often they've been disconnected from family, and they are trying to use out of public sites. So they're going into spaces by themselves and using, and then overdose alone. And so just, again, the structure of not having housing and being socially disconnected is contributing to overdose in this population. I wanted to share, I was part of the research study for this JAMA study here. That really, the impetus for this study was that we are seeing continual sweeps of homeless encampments. So one strategy that municipalities have taken is when there is a homeless encampment or a group of people sleeping in the same location, municipalities will move those individuals. They'll break up the encampment, they'll throw out everyone's belongings. It's highly traumatic, it's very costly, and does nothing to actually solve homelessness, the underlying issue. What it does is it makes people move to less safe places. And we did this study looking at the population health effects of involuntary displacement of people experiencing unsheltered homelessness who inject drugs. And what we found is every time someone is displaced, whether it's through an encampment sweep, whether they're kicked out of, from wherever someone was sleeping behind a building, every time they're continually displaced, this causes loss of medications, disconnection from street outreach teams that are trying to support or reach that person. They lose vital records like their IDs, social security cards. They lose medications if their tents were stolen or their tents were thrown away. It causes huge disruptions in people's lives, makes it harder to house and harder to get them connected to services. And we saw huge population health effects of overdose because, again, that disconnection. Again, as I mentioned at the start, if I'm a street medicine provider, I'm going to see George every Monday. And if he was displaced or he was in an encampment that I used to know where to find him, and now all of a sudden the police and municipality moved him, I don't know where to bring his medicine. I don't know how to find him. And that disconnection creates long-term harm for that individual and ultimately makes it harder to house them over time. So it's hugely problematic. I will say I understand to some degree on the other side that these are encampments are not wonderful for the public, for visual, for many reasons. People take great issue with encampments. I'll say as an advocate that my hope, and there are cities that are doing this well, that they will focus on an encampment and do line by line work to get every single person in there housed. It's a huge initiative that can be done, and they're doing great work in Dallas in particular. They have an amazing model where they line up a bunch of units and they swoop in for 30 days, and they have these outreach teams continually working with people in the encampment, and they will grow the encampment down and get those people and individuals housed one by one until the encampment is closed. And that's how we should be doing this. We should be connecting people to housing and not just displacing people. So again, just wanted to highlight a little bit about some of the intersections of policy, um, substance use, and homelessness, and how this can really cause population health effects. So just wanted to underscore, being sick can make you homeless. So I have a number of patients who had a heart attack, had a stroke, lost their jobs because of missed work. And then that loss of income leads to not being able to pay their rent. And many people don't have a safety net of friends, family, or they're one paycheck away, and then they fall into homelessness. And these are people who were lawyers, police officers, like professionals. Homelessness is not that far away from many people. And so we see folks had an illness, become homeless, and then homelessness makes you sicker, as I've described. And so the conditions of homelessness can make it really challenging. I call it this vortex for my patients. It's really hard to get out of. Lack of stable shelter, lack of food, lack of income, hygiene. It can make it nearly impossible to be healthy. And in Portland, Maine, where I am right now, there's no day space for people to shower. So if you are unsheltered right now, and our shelters are full, it's only November, it hasn't gone below freezing, but it should next week. And those sleeping outside have nowhere to take a shower. And just think about that. I had a patient on Monday who had horrible head lice, and we were trying to figure out how to treat her. And she's like, I haven't been able to shower in months. And I just, that like, it just makes me so sad and upset that we live in a country where folks can't access their most basic needs. And those are policy decisions that people have made. So let's talk about a little bit of the policy landscape and how things have been shaping up over the past year. So Medicaid cuts. So HR1 was passed July 4th of this year. And as many of you are aware, the projections are that this will divest $1 trillion to Medicaid across the country and over the next 10 years. It will be felt disproportionately across our country. But no matter how we put it, people will lose health insurance in a really big way. And a lot of states are going to end up having to cut eligibility groups or cut services because of this. And I can say that with full confidence because being on our state Medicaid leadership team, where we desperately want to keep access to Medicaid for people, this is going to be really challenging. The amount of burden placed on states with this law is profound. The CBO, the Congressional Budget Office, estimates that 10 million people lose Medicaid. They estimate that 1 to 5 people will lose coverage from the exchange. And the way that that's getting accomplished is through administrative burden, through work requirements, or what's being called community engagement requirements. So this really gets in the weeds, and I'll try not to go too deep into it because I could. But long story short is that for folks who are on Medicaid expansion, who are single adults who are going to have to sign up for Medicaid every 6 months now rather than a year, and they're going to have to either volunteer or work 80 hours a week to be able to qualify for Medicaid. And just the burden of compliance, of needing the documentation to be able to demonstrate, is going to make it very difficult for folks to be able to meet, even if they're technically eligible, just have all the documentation to support that is going to be really challenging. I'm not going to read all the things here, but I just want to share that these changes were very political in terms of when they are coming into play. And so the work requirements are coming after in 2027. So trying to put some of the direct effects to people after the next election. But there are many. We saw Planned Parenthood and Maine Family Planning lose access to Medicaid funding. There are work requirements. There are many. There's immigrant communities like refugees who will no longer be able to access Medicaid. Mandatory co-pays for expansion adults, including those who have zero income, like my patients. So this is going to be really problematic. And this is really where state. 80 hours a month. Yes, you're right, for work requirements. I misspoke. So this is where state level leadership is going to be really important in terms of how we try to mitigate the harm for our communities. And so we're trying to be really strategic of how do we automate this. If we already know there's certain exemptions to work requirements, how do we automate that within systems and not put the burden on patients to have proof of it? So we're going to do everything we can within our state government to follow the letter of the law while being as thoughtful as possible, but this is going to be challenging. We know that people will lose Medicaid. And why that matters, and in thinking of this intersection in particular, is that Medicaid expansion gave people who long for many years struggled with substance use disorders and addiction the ability for the first time to be covered and access treatment. And I know that because I worked in Maine pre-Medicaid expansion and post. In pre, we had to work every grant program possible just to cover treatment. And it made it really burdensome, very complicated for folks to have to navigate. It was really challenging. But once we expanded Medicaid, all of our patients could qualify and have access to full scope substance use disorder treatment, inpatient treatment, outpatient intensive treatment, medications, really what people needed to be able to actually move forward in their recovery journey. And so Medicaid is so essential for accessing substance use treatment. And we're deeply concerned that by people losing Medicaid, we'll see overdoses increase. We're going to see folks not be able to access treatment. And I'll say in Maine in particular, we're one of the states that have the highest percentage of our expansion population accessing substance use disorder. 30% of our expansion population has a substance use disorder diagnosis and is engaged in treatment. And so if they lose access to Medicaid, I'm really worried. All right, I'm going to move through these next slides a little faster. So July 24th, this is a presidential executive order titled Ending Crime and Disorder on America's Streets. Very disturbing title. What the implications of that executive order is, it fundamentally changes the way the federal government is approaching homelessness. It moves from a compassionate harm reduction approach to one of law enforcement, compliance, really moving to criminalization of homelessness. And this is deeply disturbing and not in line with evidence-based practice. At a high level, what the executive order does is it encourages states to criminalize homelessness, sweep encampments, and incentivizes them to do that. Not just say encourages, incentivizes, and seeks to expand institutionalization, forced treatment, and use of civil commitments to those with behavioral health conditions. And these are really human rights violations. This is saying we're going to take away someone's right to self-determination. We're going to incarcerate you or require you to get psychiatric care. And the discussion around civil commitments is quite nuanced, and I don't want to oversimplify it here because it's complicated. It, in some circumstances, is warranted. But to say anyone who is homeless and uses drugs should be committed is absolutely not true. What folks need is compassion, care, and access to treatment. People do not need to be incarcerated. All that does is further traumatize people and sow deep mistrust. And so much of what we do in healthcare for the homeless is try to build trust. And then this ends support for harm reduction and housing first approaches to care, which again goes against 30 years of deep research in this area that says harm reduction and housing first saves lives and helps people be successful in housing. This is just from the Homelessness Law Center, which is just really an amazing organization that does such important work all across the country. And they have these really wonderful blogs that you can read to really understand the implications on the national level. And then they get into some particulars in states where things are happening. So I encourage you, this is a wonderful resource to tap into, and they really explain the implications of these executive orders and how they're going to play out in our communities. SNAP cuts were also part of HR 1. And I just want to say, when you're already experiencing homelessness, accessing food is very challenging. Again, what we're seeing is a huge divestment in accessing food for people. Huge federal cuts, $186 billion over 10 years, increased work requirements, decreased number of people who can be eligible, and discontinuing of SNAP education. So lots of harmful policy here that as someone who cares deeply about food access, this is harmful for people, low-income people across the board, not only for people experiencing homelessness. All right, last part here. Grants Pass was a Supreme Court decision last year that really is going to transform the way that our country is. The most transformative decision in the past 40 years of homelessness. We're basically saying if someone is sleeping outside, if there's nowhere for them to go, the shelters are full, the cities and municipalities can continue to criminalize them, sweep them. And we have seen many, many hundreds of laws passed in the past year since this decision, criminalizing homelessness. Again, these are people who have nowhere else to go. So their existence is now criminalized just by sleeping outside. And then what we're waiting to hear any day is the HUD is supposed to release their annual, what's called their COC funding. And we're deeply worried. We have heard through leaks that there's going to be huge cuts to housing and more focus on just shelter. So we're actually going to see more people become homeless. And so there'll be more to come on this issue, but advocates are screaming from the rooftops about this. We're deeply concerned that this is people who are in housing now will lose access to funding for affordable housing. All right, so just shared a lot of really hard things. So I just want to take a moment and say, don't despair. Okay, I've been doing this work now for 20 years, and there's a lot of amazing people who are doing great work. So I'm going to talk now, I'm going to move into just one more piece around engaging people with lived experience. But I want to say, when we think of what's happening in our country with these policies that are causing harm, there are so many good people doing great work all across this country. And I heard, I was listening to a podcast recently, and they talked about the difference between optimism and hope. And it really resonated with me. I don't feel optimistic based on the data, what I'm seeing, what's happening, but I feel hope. Hope is based on, despite what I see, I know that there are people all across this country that are trying to do really good things, that are advocating, that are standing up. And so I'm going to continue to choose hope. And I know that I identify as being part of the movement to end homelessness, and this work takes generations. And so in this moment, we're taking steps backward, but we're going to need many people to be able to push this from causing so much harm and be able to do the work when we have administration change, when we have leadership changes, to be able to push best practices forward. I put this picture here on the right. This is Acadia, Maine. If you've never been to Maine, you should come. Because it's a really beautiful place. So please all come to me. All right, next piece I just want to share. Growing up, I experienced homelessness as a teenager. I had a father who struggled with severe persistent mental illness, and I grew up in poverty. And you name the public benefit, and I was on it. We had, after a year of homelessness with my mom and my siblings and I, we lived in Section 8 housing. We were on TANF. We received WIC. We received SNAP. I received Pell Grants to go to college. Like, the safety net is what caught our family. And so I deeply believe in these systems as essential for supporting human rights and to help people move forward. I also have one experience as a white person who grew up in Massachusetts in these systems. And so for me, this work deeply connects with my experience, but it's also, I personally have not been to jail. I have a brother who is a felon, who has been struggling in and out of carceral system, who struggles with substance use. So this work intersects with my lived experience, but I don't know what it's like to be an adult experiencing homelessness or a parent experiencing homelessness. And so I just want to say, what is really important and what I have come to really value in this work is trusting people with lived experience and engaging with them to come up with the policy solutions. And so we can't have top-down solutions. They don't work. They're ineffective. And so I just want to think, as we're thinking of the current state of homelessness, of where we are with these policy issues, how do we then really do meaningful organizing with people with lived experience to create more equitable systems? I really appreciate this quote by Glenn Martin. People closest to the problem are people closest to the solution, but are often furthest from resources and power. So how do we make sure when we're at tables that we're creating space and having people at that table. I often struggle when people say I'm the voice for the voiceless. Like, no, people have voices. We need to create the space for them to be able to partake and share their expertise. So here is a framework that I really appreciate from the Facilitating Power organization. It talks about ways that we can actually do community engagement, from just on one end ignoring, that can be just marginalizing. If I within state government got a grant and I just decided what to do, but I never engaged people who are going to directly, who I'm designing it for, or the organizations that are going to be providing the service. That's just marginalization. And then you go to placation, tokenization, voice, delegated power, and community ownership. So this is a really wonderful framework that I just want to offer up. And that I'll say for myself that as I've been doing work over the years, that when I learn better, I do better. And so I try to move from, wherever I am further up this and really move towards involving, collaborating, and deferring to having really delegating power, have community ownership. And I'm going to give you some examples of how I've tried to do this in some of my work. I wanted to give two shout outs to folks that I've worked with over the years. Albert Townsend, really amazing leader in our country. He's now the Director of Lived Experience and Innovation at the National Alliance to End Homelessness. I love this role so much. I worked at the National Healthcare for Homeless Council. Previously, our organizations were good partners. And we often tried to hire people with lived experience, but to have a director in a leadership role with that title, and Albert experienced chronic homelessness, it's so vital. His voice is so important as a national leader to speak from a place of experience when advocating for better systems. And he recently, as a result of the executive order, wrote this great opinion piece in USA Today that is here, and I have the link to it in the notes. I encourage you to read it. It's really beautiful, and he shared a lot about his experience and just saying Trump is wrong. I've been homeless. I wasn't a criminal. I just needed a home, and that's the reality. People aren't criminals just because they're homeless. They need support and resources and connection to resources. And I'll just share, on the right is Jess Valero. Jess is a dear friend, is an organizer in Portland, Maine, where I live. I've organized a lot with Jess over the years. And in the right bottom corner is the sleep-in protest that I mentioned at the top. That was led by Jess. And this became a 3-week protest outside of City Hall during COVID because people experiencing homelessness were given no place to safely sleep. They were still in shelters, congregate living settings, and felt like no one cared. And Jess was homeless at the time and did all this organizing. And the picture on the top right was her talking to the Portland mayor, trying to advocate for getting folks in hotels or motels or in other safer situations during the pandemic. And Homeless Voices for Justice is a advocacy organization in Portland made of all people who've lived experience of homelessness who advocate to city council and to our state legislature to create more just policies. So 2 examples of state and national leader who are using their experience to advocate for better policy. And Jess actually ran for city council. She didn't win, but she's done such a great work and is so deeply respected across our state, always uses her experience to try to advocate for better policy. So one way in my work, Molly referenced in the beginning that I am working on 1115 reentry waiver, and that is to try to utilize a mechanism within Medicaid to cover services for people who are incarcerated. And I just want to say we've done 3 things so far as part of this work. We've partnered with community-based organizations to be able to compensate them through grants to help lead some of this work. We have done listening sessions in jails and prisons and help present on this to get their direct input of how they think we should shape the implementation plan. And we're developing a community advisory board of people who've been justice impacted to help develop our implementation plan and to hold us accountable for the goals that we set with this initiative. So I just want to give one example of how we within state government can do this. Partner with community-based organizations, partner with people with lived experience, compensate them for their time and expertise. And just to note, we compensate them as the same rate that we would for any subject matter experts. I pay them at least $90 an hour because we want to be equitable and compensate people for their expertise. And then lastly, again, don't despair. Just want to leave you with a few things. I know it can be overwhelming if you hear a conversation about all these things that are not going great and you're like, don't slip into despair. There's lots of things you can do. Vote. Local elections always matter. Get involved locally. Consider running for a local election. Testify at your city council meetings. Pay attention to what's coming through your city council. Volunteer locally. That makes a huge impact. It helps you feel like you're being part of the solution. Mutual aid is so important in times like these when there's high mistrust. And follow your passion. I said this a little bit in the beginning. We can't all do all the things for everybody, and that's okay. Whatever your passion is, follow that, because I can't. I'm squared in on Medicaid and supporting people experiencing homelessness, but I need people who are doing other parts of the work, and so we all need each other. And so don't feel like you have to fix it all. Just figure out what your passion is and follow that and work on that in that corner of your world. And that's it. So here's my email. Here's my LinkedIn if folks want to connect on LinkedIn. I'm an open book. If folks want to ever reach out, chat, please do. But I'm going to take down the slides now, and I welcome any thoughts or questions.
Thank you so much. We're going to start with questions from those of us in the HAPI program, and then if there are any people from the addiction policy program before we open up to the general public. Haley.
Hi, Courtney. Thank you so much. That was an amazing presentation and incredibly informative. I had a quick question. So I am from Nevada, and based on the state policy map that you showed, I was just wondering if you knew why the majority of change reduction was occurring mostly on the East Coast as opposed to the West Coast, or if like the changes were more impactful over here rather than on the West Coast. Like, is there something on the West Coast that we should be doing more?
That's a great question. Did Nevada expand Medicaid?
I don't think so. We also have an increasingly large amount of rural populations that are also disproportionately affected by the rural cuts or the Medicaid cuts. So I was wondering if that was playing a role into it.
Yeah, so my quick Google search is telling me that starting January 1, Nevada will expand Medicaid, but it hasn't yet. And so I do think you leave so many people without access to care, really people in low income that are right above Medicaid but can't really afford the exchange or haven't been able to access care that way. But I work in a rural state, and you're right, accessing care in rural communities is exceptionally challenging. It takes more resources to bring resources to fewer people. And so when your state is struggling financially and state budgets, it's easier to support more people in urban centers. And so I do think that's where really all state government and helping to bring resources to the last mile. Like, we have counties in Maine that didn't have access to methadone clinics. And so we finally just got a mobile methadone clinic to go to those last few. And so it takes really significant strategic planning to really focus on some of those rural communities. So I think that combination probably is making it really challenging in Nevada. I also know that Nevada has struggled embracing harm reduction. And so there's a lot of organizers that have been trying to do harm reduction work in Nevada in particular.
Yeah, we have like a few specific mutual aid groups within Reno, which is where I live, that really focus on harm reduction for the houseless population. So yeah.
That's great.
Thank you.
You're welcome. Yeah.
I can ask a question while people are still thinking. I'm curious to hear more about the program you had mentioned working with improving health outcomes for people who are being released from incarceration.
Sure. So it probably no surprise to anybody, people who are incarcerated have really poor health outcomes. And following release from jails and prisons, 120% increase in likelihood of an overdose mortality. And so this is a huge area, room for making improvements. There is what's called an Inmate Exclusion Act, which prohibits the use of Medicaid in jails or prisons. And so historically, jails are funded by counties and states fund prisons, and they are required to provide health care. And you can imagine that varies widely and is often really poor. There's very little transparency into the care provided within jails and prisons. And so under the previous administration, they opened up the possibility of applying for a waiver of that federal rule to allow the use of Medicaid for people in jails and prisons 90 days before they're released to pay for case management, to cover substance use treatment, and to really focus on improving reentry planning so that person can return to the community with a plan, know where they're going to sleep, how they're going to get their medications. And so that has been the focus of a big part of my work the past 2 years, is trying to design this. And it's brand new. And so it's taken a lot of community engagement. It's taken going to every facility in the state, engaging with people with lived experience to really understand what their needs are, what their challenges are, to try to create a system that's going to improve health outcomes.
We have a question too from Jero in the chat, so I'll read that. Thank you so much, Courtney, for this amazing presentation. I wanted to ask about what has surprised you the most about how listeners of your podcast interpret the relationship between you and your former patient. Do they see it as professional, personal, or something in between?
That's an interesting question. Maybe I asked that back to the group. One of the ways that I personally approach substance use treatment is through mutuality and saying that I'm really accompanying someone in their journey. Someone sees me for a few minutes. I mean, I see my patients often who are struggling with chaotic substance use once a week. So I might see them every single Monday. I don't know if you see your best friends or your family once a week, but it's a lot. Like, that's a lot of time to see it. So I might see my patients more than most people in my life in over years, many years. So it's a longitudinal journey. But I'm not naive there's no magic that I have. There's no magic wand. And the journey of recovery is up and down and winding. And so people can have the right to self-determination. People can return to use or relapse if they identify it that way. And it doesn't change how much I care about them and how much I'm there to support them regardless. And so for me, it's not about really like a doctor-patient relationship, though I am. It's about how do I best support you in your goals, in your journey, in your recovery, and supporting them and alongside, rather than this patriarchal, I'm telling you what to do, here's a prescription, you're supposed to do X, Y, and Z, and if you don't, sorry, you're out of my practice. Like that doesn't help serve people, and especially people who've been some of the most marginalized in our society. There's so much internalized shame and stigma for someone who has used drugs, people who've had to do survival sex work, people who are sleeping outside. And so adding my own, you shouldn't have done that, does no good, right? Like there's so much shame. So the most important thing I can do is create a space of compassion. And over time, as I get to know folks, I'm not there to share my burdens with them, but I also, sometimes it can be helpful to say, I experienced homelessness too, or I had a father that struggled with mental illness too, and help people relate to my humanity. And it's not that they can call my cell phone 24/7 or they're coming over my house. Like, I have boundaries. I think it's okay and important for providers to also share that they're human too, and it helps to build trust over time. But I welcome your thoughts about that, and because I think that relationship is atypical in healthcare, that mutuality, and I think it is somewhat radical, unfortunately. But I welcome those that listen to the podcast to hear your thoughts too.
June, are you there to ask your question, or should I come back to you? We will skip and go to Noah's question in the chat. And she says, thank you so much for an incredible talk and congratulations on all you've accomplished. I wanted to follow up on your discussion about the homeless veteran population. Do you feel there has been an increase in bipartisan support on this issue, given the increased public awareness and media coverage of veteran housing issues? And do you think that the same bipartisan support can be seen for the issue of homelessness as a whole in the future?
So I think this is a fascinating question, because I've heard, you've probably heard this too. Well, why would we do X? We have veterans who are homeless. Like we need to take care of our veterans. And so it's a group that absolutely has had bipartisan support. And there isn't the same victim blaming, or like you need to pull yourself up by your bootstraps, or you didn't manage your money, or you need to work harder. For some reason, for veterans, there is compassion across both sides of the aisle, which is wonderful. I just wish that was extended to everybody else. And because I do think that has helped allow funding and the support across all the federal government and state governments to actually address that policy issue.
June, you're up.
Hi, thank you so much for this wonderful talk. It's been really, really incredible to kind of hear about these issues and how they intersect. I was wondering, you touched on this a little bit at the beginning with the kind of map of like where how addiction and overdose rates are sort of projected to go by state. And I was wondering if you knew or if like you've seen like what kinds of state policies are the best predictors of kind of which direction those rates are going to trend in.
That's fascinating. So I haven't seen any resource to that end because one of the things I said in that slide was state policy and environment. And it goes back to something Haley said is Maine is a rural and poor state. Like poverty also impacts access to resources and housing. And so those kind of go hand in hand. So what's the environment and policy? So it's a little bit of both. And then when we think of how do we actually address this problem, again, it's multifactorial. It's the prevention. So how are we working on multi-generational poverty, the really 2-generational approaches of how do we help parents and kiddos move out of poverty, and how do we prevent and support parents access substance use treatment and get the kiddos into prevention and supportive services. So 2-generational approaches to treatment and prevention, accessing treatment, and then for those that are in active use, harm reduction. And so it's, and then you think of a state like California that has taken those approaches, and yet the environment in which California is in is they have some of the highest housing costs, so they have the highest rate of homelessness. And so they have a huge rate of homelessness, and they're so far downstream in terms of needing so many more people to access treatment and housing. And so every state is going to have a different constellation of these things. And so that's where federal government is so important for opening up and accessing funding for treatment and sharing best practices of approach. But then it's also going to be state level impact and the nuances of the environment in each state too. And that's hard if your state is struggling financially, which many are right now.
Okay, I see we also have another question in the chat from Kiana. She says, amazing presentation. My question is on education. For the general public, what resources do you suggest to help understand the nuances of homelessness and the comorbidities that it brings to help encourage empathy and bring awareness to the need for change?
So this is an interesting one. I'm sure at some point in maybe this program, you've learned about adverse childhood experiences. Yes. So for people who have had 4 or more adverse childhood experiences, you're 12 times more likely to use injection drug use, right? So these things start early, experiencing poverty, abuse, neglect. It's really easy to garner public compassion and care for those kiddos. Those kids deserve care and all that compassion, but those same kiddos are my patients now as adults. And then no one cares about them and they don't care what happened in their childhood. But we initially, when we started our Suboxone program to treat opioid use disorder, we were doing ACEs screenings and we stopped. 100% of my patients have 4 or more adverse childhood experiences who are homeless and use drugs, 100%. And so there's something along the way in our society that we have these stacking judgments about folks who use drugs and who are homeless. And so I don't think that there's one easy way, to be honest with you. I don't think there's like one great resource to help someone like see another human compassionately who is struggling in our society. I think this is deeply rooted. And I honestly, it's how do we support people just seeing each other's humanity? Like I personally I've been in a unique position where I grew up in poverty and then I got to go to a school like Georgetown. And so I can talk to our governor and I can go on the streets and talk to my patients. And I don't think anyone is above any other human. I think everyone has an inherent dignity and worth. And that's my personal perspective. And how do we just help other people see that? I don't know. So if you have any bright ideas, I love them. But it's hard. I find it really personally very challenging. to argue for someone's humanity.
Yes, you're welcome to go. I think pretty much everyone from the cohort asked a question so far.
Thank you. I'm sorry that I'm on my iPhone in transition, but I loved your talk. I love your work. And I think you were asking for thoughts on how you relate to certain patients. And I agree wholeheartedly that finding a way to relate to your patient is the way towards the heart and the mind of that patient. Having the doctor, the physician, the nurse in a pedestal and the patient down there is not going to get you anywhere. The best example would be, for instance, getting someone to take the COVID vaccine. You can blurt out all the statistics you want, but that's not going to convince your patient. What it's going to convince the patient is, I'm a mother like you. I also have those concerns, but I decided to go ahead because of this and that. So there is a way that every provider can find out a little more about the patient or the person they have in front, and they will find something to relate to, because we're all humans. If we don't find that channel, I'm not sure the communication is going to be very effective. So thank you for doing what you do and for doing it how you do it.
Beautifully said, Olga. Thank you so much. I think your examples are spot on.
So, Courtney, this is Adam. I have a comment, maybe a question, and I'm going to try to get it out while my dog's not barking too much. One of the things that I've observed, just in spheres that I go into, is that when we're dealing with children and youth, the same behaviors associated with substance use and the sequelae of those of that are treated medically. They're treated as psychological, psychiatric, medical issues, right? And then as people mature, or as they get older, maybe they're not maturing as if they're using, but anyway, it becomes a legal thing, right? And why that happens is pretty clear, because as people become older and their responsibilities and expectations change, it's harder for them to navigate into to their substance use or psychiatric issues without running afoul of laws that were always there, but were kind of sheltered from as youth. But once you enter into that system, oftentimes you're getting into a world where you only make matters worse, right? That people who go into institutions, especially jails and prisons with substance use, in most cases, the recidivism rate is super high, and the programs that they have aren't particularly useful. So those are run by different groups, right? The carceral system versus the medical system. And what kind of big changes in our thinking might be possible to kind of, try to navigate that to where everyone's has the same goals in mind and maybe better outcomes?
Yeah, I think it's a good point. I'll say, after 2020, we saw lots of conversations around defund the police. And unfortunately, that got weaponized. What we saw, though, are models that are co-responding of behavioral health units with police, or behavioral health units embedded within police departments, community engagement teams, that if someone is having a mental health or a substance use crisis, rather than incarcerate them, they have the behavioral health unit that can go out and say, do you need to go into detox? Do you need substance use treatment, rather than just incarcerate someone just for the simple act of using drugs. And so we have seen municipalities that have developed that co-responder model be very effective helping to reroute rather than actually getting someone into that system that, just like you're saying, ends up going on to cause more harm and not access any improved treatment outcomes. And so I think co-responder models are really effective. And then it really helps police who are not mental health or substance use experts not respond and be present in those situations. And then I do think the 1115 reentry waivers and HARP, I don't know if I can quickly find it, but HARP is the national organization that's really doing a lot of great work around reentry waivers. And folks see the reentry waiver as one of the most important criminal justice reforms in the past 30 years, because it's going to improve access to treatment, standardize MAT within jails and prisons, which right now is the wild, wild west. Like every jail and prison does it totally differently, and there's no standards. And so having Medicaid to actually have a payer in 25 states have applied for the reentry waiver. So it has been bipartisan because a lot of jails and prisons are saying we can't afford to do MAT. We might want to, but we can't even offer it. We can't afford it. And so many states are now opting into doing the reentry waiver, which is going to allow transparency into the healthcare provided. It's going to improve access to MAT and care coordination. So I think those two things could be really impactful. I know we only have 2 minutes left, but I just wanted to see if folks had any other questions on the podcast and the conversation I had with Sam, or reflections.
So not hearing any of the students bring up anything, I think they're a little shy about that. I wanted to just mention that we had a talk a couple years ago by another former Georgetown student who is a street doc who works for Unity Healthcare, but is given 2 days a week to go wander the streets of DC, and he had a very similar approach of, first making friends, getting to know people, and, going back another time. And it took him weeks or maybe till never to get somebody into the system. But I think that approach of acting as an advocate, a friend, someone who sees and hears and doesn't push someone too hard is great. And you were exhibiting at a high level a lot of the same things that my friend and former student was talking about here. So I could appreciate it very much.
Well, thanks so much for having me. It's really a pleasure to talk with you all today.
Yes, we really appreciate it. And I will make sure that I send out the slides to the rest of the cohort as well.
And Courtney, do you mind the slides going out, or do you
Not
just
at all.
want to? Okay, good. Thanks.
Yeah,
You can just email me and then I can forward them.
Okay.
Thanks so much, Courtney. You're a great representative of the Georgetown alumni, and so happy to have you here today.
Thanks so much. Hope you all have a wonderful day. Take care.